Operational issues are really becoming a high-frequency issue in emergency medicine malpractice. Now, diagnostic errors and delays in diagnosis remains the top issue. However, there was a study done recently by a large physician medical malpractice company that showed that 30% of all now related to operations. Now, some of these issues include handoffs, radiology interface, consultants, teamwork, as well as efficiency issues such as length of stay. When we're talking about operational issues, we're talking about the system issues. It's how care is delivered. So let's talk about contributing factors of the issues I've raised. First, handoffs. In regards to handoffs, it's really all about communication. Now, it could be at shift change. It could be between provider and another provider. Sometimes it's actually not providing all of the information that needs to be provided for the next oncoming shift. In regards to efficiency issues, we're really talking about length of stay. And sometimes it could be related to door-to-doc times. In general, the expectation is that a patient should be seen within 30 minutes by a physician from the time of arrival. Now, that doesn't always happen, and there's a multitude of reasons. It could be volume surges, it could be a backup at triage, it could just be the overall patient flow, the throughput process, or delays in turnaround times. In regards to consultant issues and looking at some of the contributing factors there, what we're really referring to could be the failure of our ED physician to actually document that conversation. It could be canceling of tests or not ordering the type of tests that the ED physician thought the consultant physician would. It could be a failure to admit or to observe the patient.
One of the rapidly rising areas of malpractice litigation for the emergency department involves radiology. And again, it stems from the issues of handoff and communication. To start off with, the first area of concern is really the preliminary reading to make sure that the wet reading by the radiologist in terms of the ED is communicated back to the ED, but it also becomes part of the permanent medical record and can be referred to, because we're using that evaluation to make a clinical decision about the care of the patient. The second area really has to do with critical data elements, and in terms of, as opposed to lab values, in terms of things like an abdominal aneurysm that's identified on a CT scan. That's a process that should just stop, and at that point there should be some kind of physician-to-physician communication when it's recognized that there's a critical potential or life-threatening area that's identified on an X-ray or some kind of radiologic evaluation. We want to ensure that that happens, and sometimes it doesn't, and it results in a delay in the care of patients, and so on both sides, we're accountable for that, and so making sure that critical access data elements as well as the preliminary wet reads are communicated. The last would really be the overreads. Not only overreads that the emergency physician may do in terms of evaluating or having a second set of eyes look at it, but the overreads the next day or the next shift for radiology when another radiologist interprets the initial wet reading, and ensuring that there is accurate communication of that data back to the emergency department. For patients that are admitted or who need specialty consultation in the emergency department, the handoff of care and critical data elements to a consultant is incredibly important to get that streamlined and decrease any potential errors for communication. So there are several steps involved. One is accurate and timely documentation in the medical record of that conversation that happens between the consultant and the evaluating physician. The second is to ensure that all critical labs or any pending labs that the consultant may need to be aware of are communicated to them. The third is really the case of a patient where we really want to sort of keep eyes on. In other words, we don't want to let that patient who may be septic or have a low blood pressure in the emergency department. We really want to watch them until there's actually a face-to-face transfer of care and the admitting physician or the consulting physician arrives and evaluates that patient in the ED. There's no question that that increases patient safety and decreases medical error. And the last is really change the scope, if you will, of risk management in the emergency department, and that is, we used to, if we couldn't figure out what was going on, be pretty safe in just admitting the patient to the hospital. That's no longer the case. And we've seen litigation for delays in treatment and diagnosis. In other words, they didn't get admitted for 10 hours. Gee, doctor, what did you do while the patient was in the ED? In other words, did you give them all the medications they needed? Did you order all the tests? Did you get the appropriate consultations? The next area of liability would be, did you admit them to the right level of care? If you're really worried about a patient, why did you put them on the floor as opposed to perhaps a monitored setting, telemetry, or the intensive care unit? So these are, just because you've admitted a patient, you're no longer home free in terms of malpractice litigation in the ED. And in terms of conversations with consultants, we need to make sure that the transfer of information is communicated in a streamlined fashion.